Oh, we didn't.
No, we're good.
Okay. Okay, so we're going to start with bronchiolitis, and so this was a review article that, and I can send you guys the PDF if you're interested. And this was a multi-center, like they looked at multiple RCTs that were done across the world as to how everyone treats bronchiolitis. And this was again looking at the developed countries. So they looked in North America, they looked in Europe, and they looked in Australia, New Zealand, how their patients are treated, and they came up with these recommendations. And I thought that would be really helpful to know, especially because this is the season for bronchiolitis. So 34 million new cases every year happen for RSV, and most of them are less than 5 years. 10% of them get admitted to the hospital. And in the developing world, it's really bad. I mean, they have up to 200,000 deaths just from bronchiolitis. And in the United States, it's the leading cause of hospital admissions in kids less than 1 year of age. Again, these are the ones who have increased severity. They've increased ER visits, increased rates of respiratory failure. And I was looking at a study, and I had those couple bullets in my updated slide, which I don't have here. They found that kids, of all the kids who die due to bronchiolitis in America, 55% of them are less than 3 months of age. And prematurity is the single most important risk factor. So if the kids were born extremely low birth weight, at a higher chance of dying than the low birth weight, than the babies who are appropriate for gestational age. So if you are taking care of a patient who was a 25-weeker in the NICU who weighed like 800 grams and they're now 10 months, 11 months with bronchiolitis, you should be more worried about that patient compared to a 6-month-old who was stern baby and who has bronchiolitis. So as we talk about how important history is, knowing that for comorbidities, whenever I get a call from transfer center, I always ask if the baby was term or preterm. I think that's always important because they don't have normal lungs to begin with. So how do you define bronchiolitis? Anyone?
Isn't it just inflammation of the bronchiole?
Yeah, it's just, so it's itis is inflammation, bronchioles are the smaller airways, so it's inflammation of the bronchioles, and the most common causes are the viruses, and RSV is one of the most important one. The age group, again, majority of them are usually less than 2 years. So, and again, this is just more semantics. If you have a 2-year-old with, you'll say bronchiolitis, but if you have a 3-year-old, we'll probably say RSV pneumonia. It means the same. So pneumonia doesn't always mean bacterial infection. Viruses can cause pneumonia too. Just something, because the moment you say pneumonia, the first thing that comes to your mind is like that lobar pneumonia, the classic strep pneumonia, but that's not. Viruses can cause pneumonia too. Again, it's seasonal, so we know November through March is the peak. So the winter months are the worst for causing bronchiolitis. And environmental tobacco smoke is associated with very increased risk of bronchiolitis with RSV. So something when you guys do your initial intake, asking about passive smoke exposure is always important. Again, severe RSV for some reasons is more common in males than females, and some of the risk factors for, again, severity of disease we talked about, less than 3 months, very high risk. If they have a cardiopulmonary disease, so if they had like a congenital heart disease that they're like operated for, or in a palliative procedure, or if they have an immunodeficiency that they're dealing with, they're going to have more risk of causing severe RSV infections. Because these are some of the questions that the parents ask us, right? I mean, is my kid going to get intubated? We really don't have that crystal ball to say who's going to be fine, who's going to just need hypo, who's going to need intubation, but we know that if they're premature and if they have these risk factors, then you can say there's a high chance that they might get sicker. For example, we had a 25-weeker, a 15-month-old with human metapneumovirus bronchiolitis who was doing okay for 48 hours, and then she decompensated, needed a ventilator, and went to an oscillator really quickly. So that again tells us that prematurity is one of the single most important factors. So coming to pathophysiology, again, just basic. So there's extensive inflammation. There's a lot of airway edema, and there's increased mucus production. We all know, when we suck out the mucus from these patients, they just have a lot of this. What do you think all of this leads to? What does it do to the airway? Anyone? What do you think, Tammy? Like a combination of inflammation. Sorry to put you on the spot.
I know, and I was only half paying attention.
Okay, so a combination of inflammation, edema, and mucus production. What would it do?
It's gonna increase their work of breathing. They're gonna work harder.
Absolutely. But what would it do to the airways?
It's gonna decrease the airway resistance, so.
That causes swelling.
Yeah. So you said you meant it, but you didn't say it the right way.
Okay.
So decrease the diameter, increase the resistance. So if you remember from your nursing school times, the physiology, they talk about, so your radius or the diameter is inversely proportional to the fourth power of the resistance. So the resistance is inversely proportional to the fourth power of radius. So if you decrease their diameter by 2, so if you halve their diameter, their resistance increases by 16 times. So just imagine for little babies, and the younger they are, they already have smaller airways, and you put all these 3 into them, they have significantly increased airway resistance. So when adults get RSV, it's just a cold, but when babies get RSV, it's a matter of for them to breathe. And does that make sense? So it's just increased airway resistance due to all these. There can be necrosis of airway epithelium. There can be ciliary destruction. So they may not be clearing their mucus effectively because the ciliary clearance is our natural mechanism, and that gets affected. They can also have bronchiolar obstruction, so we can sometimes see distended airways despite they're not breathing the best, and then all of
Necrosis of airway, what's that from? What would it mean? What is that?
it's a part of inflammation. So with inflammation, you can either get necrosis, you can get fibrosis, or you can have resolution. And then multiple viruses, if you have multiple viral infections, they can cause fibrosis. So you may not end up with normal lungs after every infection. And that's the reason why the preemie lungs, they always don't have like a normal looking x-ray. They always have a baseline hazy x-ray. This is really important, airway collapse, because airway collapse is what we call, in the medical term, atelectasis, which can look like an infiltrate. And a lot of times when we see an infiltrate on x-ray, we tend to give them antibiotics because it could be pneumonia. But again, to remember is that it could just be atelectasis. And a classic feature of RSV is the roaming atelectasis. What that tells us, and this will happen to like all of you, like if you're going to take a listen and if you're going to listen, I don't hear much air entry on the right side, and then someone else comes and takes a listen, and they're like, oh no, I don't hear it on the left, and you're like, but I'm not lying. I did listen to the patient, and this would happen to like me as a resident or a fellow, and then you would hear something different, and the attending would hear something different, and like, no, I'm not lying. I did do my physical exam, but that's the classic with RSV, and they just look so different. Like they'll look fine the minute, and the next assessment you're going, or even before that, they'll look like as if they're just they probably need to get intubated. So that's classic of a bronchiolitis. They keep you on your toes. So more than 50% of all bronchiolitis are RSV, up to 80% in some literature, and then the list goes on. And then human metapneumo is the second most common, and it usually follows the RSV trend. So like what we talk about RSV is day 3, 4, 5. It gets worse before it gets better, and human metapneumo of all the following will have that particular trend. Human rhinovirus, again, it's just more the cold and the coryza. The rhinorrhea is more common with it. Influenza, as we well know, is and gets much sicker. Paraflu usually will cause a predominant cough. So if someone presents with croup or airway obstruction and have bronchiolitis, you're more worried about paraflu. Paraflu 3 is one of the most common. They'll cause croupy cough. Adeno, what do you think? Like, what other symptoms other than bronchiolitis will they have for adeno? What do you think, Caitlin?
Aren't they coughers too?
No, I mean other than
Oh.
respiratory. What are the other things that on exam you will see which will make you think, oh, this could be adenovirus? Which other body system does adenovirus affect?
GI.
GI, so diarrhea, and they'll have conjunctivitis. So if they have conjunctivitis with diarrhea and breathing fast, it may be adeno. Adenoviruses usually are very virulent organisms. If you have a premature like ex-preemie who gets adeno, you should really watch for them. They have a potential to get really sick. And then 3 years ago, we saw a big outbreak of enterovirus in the fall, and it's still there. So the D68 is the one that is more respiratory predominant, and again, it'll cause more like a bronchospasm, like a reactive airway picture, before it becomes more parenchymal. Well, they'll have more crackles and increased secretions. And then they found 30% co-infections, RSV and human rhino. And you might see this on the respiratory viral panel. They have more than one that come back positive, but that's the most common association that they have seen. This is just a picture showing, how the symptoms go, and by the time, and you can see how there's this peak, and we talked about the minute-to-minute variability of symptoms, where they can look great 1 minute, the other minute they may not. And as you can see how this is like a normal bronchial lumen, and here, and then how it gets obstructed with all the inflammatory debris. Any questions so far? So how will they present? So, and I had a nice picture. It was the same picture that Mary Jo had with the retractions. I had got that. So the symptoms, again, for these patients are going to be as we talked about. So the non-specific URI, so they'll have this cough, cold, runny nose, and then usually when they come to the ER or when they get admitted, it's usually the increased vocal breathing. So again, they're just spending all their energy in breathing, so they won't have they'll have decreased PO. If they're not drinking well or eating well, they'll have decreased urine output. They may or may not have a fever. So those are the symptoms that you will see. Again, depending on if they have like adeno or something, they might have associated diarrhea. So coming to signs, and the way I think I look at the signs for bronchiolitis, it's if it's babies, it's very difficult, but if you can make it as objective as possible, I feel it's easy for you to translate what you think the patient has to the physician or to who is going to come after you for the next shift. So I try to keep it as objective. So there are two things to look for. One is the vocal breathing, so that's mainly from your retractions, your respiratory rate, and as you are very well aware, the monitor doesn't give the respiratory rate accurately. So it's the least accurate thing because it goes by your electrical impedance and your diaphragm motion. And a lot of times if your chest moves a little bit, it'll pick up a respiratory rate. So sometimes kids might be just breathing 30 times a minute, but the monitor might say 60. So I never go by the monitor. You have to physically count how fast they're breathing. And the third thing is your pulse oximeter. So respiratory rate and pulse oximeter are pretty objective, where you can quantify and say, well, this kid was breathing 40 times a minute, now it's breathing 60. But it comes to retractions, again, it gets very, that can be subjective. So the way I remember, and when I assess a patient and to know how sick they're getting, is if your retractions will go from, they start below, and if they go upwards, that's telling you the kid is getting sicker and sicker. So what's the most important muscle that we use for breathing? Diaphragm. So if your diaphragm is working harder, what type of retractions will you see? Subcostal, right? And what are the next muscles that will kick in if the patient still has vocal breathing? Intercostal muscles, right? So if you have intercostal muscles that are working, you'll have intercostal retractions. And then when you use your sternomastoid, your scalene muscles in the neck, will have your suprasternal retractions. And then sometimes they'll also have your alanasi, they'll dilate, you have the nasal flaring. And then kids less than 6 months, they have a bigger head to body, so when they breathe fast, they move their head, so you see the head bobbing, which you won't see in older kids. So as the retractions go upwards, you know that this is a severe, they're worsening respiratory distress. And there are multiple scores that are available online, and each score will have these or not, but just if you look at the degree of retractions and what way they're progressing, I think that's a good way of knowing. Sometimes the kids will make an end expiratory noise, what do you know what is that called? A grunt, yeah. So end-expiratory noise is where they're just trying some way on their own to keep the airway open, because as we saw in the previous slides, there's significant airway collapse. So if grunting is usually a sign of advanced respiratory failure. So if someone's grunting, you really need to be put them on high flow. If they're not on high flow, if they're already on high flow and grunting, you may want to get more help. So you need to escalate their support.
With the signs, prior to even your subcostal retractions, what about your abdominal, like when you're using your abdominal muscles?
So for kids, their chest muscles are not that strong. So they're gonna have a predominantly like a protuberant abdomen. Kids up to 2 years have a physiologic lumbar lordosis. So they always walk with their belly outside. So when they're breathing fast, they're always gonna have that predominant belly. But one of the most important things when you look is, and I'm glad you brought that up, is when you breathe in, you expand your chest. So your chest goes outwards. When you breathe out, your chest goes inwards. If your chest is going inwards when you're breathing, what we call chest indrawing or the seesaw breathing, that's usually a sign again of respiratory failure. A lot of times we use these terms, I think we use them loosely. Oh, the kid is tiring out. But what do you mean by that? Because just saying that doesn't help, right? I mean, are they lethargic? So if you say, oh, the kid is lethargic, they didn't move when we poked with an IV, or when they breathe in, their chest is actually going in instead of going out. I think those are the signs which tell you these are dangerous signs where they need more pressure than high flow, maybe like a CPAP or BiPAP or intubation. So again, looking for those signs. So thank you for bringing that up. So chest indrawing instead of going out with inhalation, so with inspiration is always a sign of advanced failure or like a respiratory fatigue. So the reason I put this differential diagnosis slide, and I think this is important, if the viruses can affect the bronchioles, they can affect other organ systems as well. And one of the common organ systems that we are worried about is the heart, or the heart muscle, the myocardium. So if you have RSV bronchiolitis, you can have RSV myocarditis as well. The reason this is important is because in patients who have RSV myocarditis, if you give them a lot of fluids, they're going to worsen. Their heart is going to fail. They'll go into cardiogenic shock. A lot of times we will give them beta-2 agonists, like we will give them a breathing treatment with albuterol or racemic, and all these medications increase your heart rate. They're increasing the oxygen demand on the heart. So you have to be very cautious when you're using these. So if you're doing an intervention and if it's not helping and if it's worsening, you should always make sure that, is this just bronchiolitis or is this something else? If you get an x-ray and if you see cardiomegaly on chest x-ray, if you just see a lot of, infiltrates, you should be worried about, myocarditis, and the treatment is different, and that's the reason, I always ask what's the heart rate? If someone's just laying comfortably, sleeping, and if it's a 6-month-old and the heart rate is 170, that's not normal. You need to make sure that if their CO2 is okay, or if they're not anemic, or is this like, if they have myocarditis, and especially if you're giving a fluid bolus for some reason, if the heart rate is not coming down, then you know that you'll probably have a cardiac involvement. So pulse oximetry is one of the single most important way to diagnose. They found that if the kids were hypoxic, that means a pulse oximetry of less than 90% on room air, those were the kids who are going to not do well. And that's the reason when I get a call from a transfer direct or outside ER or our ER, and they say, oh, they came in, they were like 80% on room air. That always, that alarms me more than someone who was breathing fast but maintaining their oxygen numbers. So hypoxemia or hypoxia on admission is always a sign that they're either not going to do well or they may have a longer hospital duration than someone who did not come hypoxic. And they've looked at many different parameters, and they could find only one that was associated with poor outcomes, and that was hypoxemia. So that's something, if you get in your nursing report, always ask, what did they come? What were their saturations before you did any interventions? And if they were hypoxemic, that tells you that this kid is probably not going to do well.
But you have to be careful.
That is true. No, absolutely. I think
Because
that's a
they'll tell you
great
they
point.
had 80 but they're pink and perfusing well. Well,
Yes.
you're not pink and perfusing well if you're 80.
Yes, and plus, I think that's a great point, because sometimes they don't have a good waveform, so they'll just put a pulse ox and whatever first number that comes up, and a lot of those digital ones may not pick up. So no, I think that's a great
I
point.
think for young nurses though, you can rely on this number, but you need to look at your patient.
Totally. No, I totally agree with that. Well, I'm trying to say like more when you're getting an admission, like an initial intake, that initial pulse ox, what they
But that's
presented.
what I mean, when you get report, try to remember,
Yes.
you
Yeah.
have to look at the whole patient. You
Totally,
can't just
yeah.
look at the one number.
Yeah. No, that is true. Absolutely.
The other thing to know with that is a lot of our outlying hospitals that refer patients to us do not have the ability to do pulse oximetry very accurately on
Mhm.
pediatric patients. They have the alligator clip,
Right.
and for
Mhm.
babies and smaller kids, that's not very accurate,
Yeah.
so.
They can't look at a pleth and,
Right.
but they can correlate a heart rate, so hopefully they do
Yes.
that, a little bit of their skills, but
And a lot of times, if
You
the
know,
kids come in,
yeah.
they're cold. If your peripheral perfusion is not good, your pulse oximeter is going to get affected. We see that a lot here as well. If you're cold, your pulse ox is not going to pick up. So, chest X-rays we talked about, and I talked to residents as well. A lot of times, if you see an infiltrate, you want to you have a lower threshold to put them on antibiotics, and I usually am conservative with not giving them antibiotics because they're in the ICU or the floor. You can monitor them and see what they're doing. Again, if they had initial hypoxia, that's more suggestive that they may develop a superadded bacterial infection than if they were not hypoxic. But again, infiltrates can happen from just atelectasis, which could be from viruses. Especially if your X-rays, like if you're getting multiple X-rays like every day or in 12 hours, and if you see they're changing infiltrates, because if it's a pneumonia, it's not going to go away in a day. But if it's a collapse, it'll change. Your opacity will change, and then you'll feel more reassured that this is not infection. And again, we talked about concerns for pneumonia. So if they have a fever that's 39 degrees Celsius or above rectal, if they're focal findings which are consistent. So if they have diminished right upper lobe and that stays that way, not the ones that keep changing, grunting, hypoxia are more suggestive of they may have a superadded bacterial infection. And then your viral testing, which is the PCR. And it's interesting to know the gold standard is PCR because last week I took care of a patient here. He got intubated. His RSV, what they do, the rapids, are the enzyme immunoassay studies. And his RSV was negative by that, but positive by PCR. And then we were not sure if he really had RSV, so we got a panel, and he was positive. So always, it'll actually say in Power Chart how it was tested. So if you strongly feel this is RSV, and if it's just done by enzyme immunoassay, and if it's negative, you should always get a PCR. That's the gold standard. Again, so this is again an important thing. So we, especially for kids who are less than 4 weeks, because again, we all are aware if you have a fever of 38 and above rectal in a less than 4 week old, you probably need a full sepsis workup, because if that kid came to the ER, would get a blood, urine, and a CSF. If you're RSV positive and if you're in the hospital, I would debate if they're otherwise neurologically okay, you don't need a CSF, but you at least need a blood and urine culture for these patients, and urine has to be, again, straight cap. So there's a high association of UTI with febrile RSVs, and so you should, especially if it's RSV bronchiolitis, and if they have a fever, you should send a urine culture. So sometimes when you're not able to, you already have an IV, you're poking them, you can get blood. The one minimum thing that you can do is at least send a straight cath UA and urine culture. And I just wanted to put this X-ray. So this is the classic X-ray that you're going to see on most, and the classic peribronchial thickening or peribronchial cuffing that they talk about. And this is how it looks, more bright at the next to the peribronchial area, and then but you can see that these lines go up all the way here. So so that's going to be the classic X-ray that you see with bronchiolitis. And this is just, again, I'm not going to go into the detailed statistical studies for here, this was just looking at they looked at bronchodilators like albuterol, racemic, a combination steroids, and then what helped and what did not. And this is just I just put together all these slides, and so this was, they looked at albuterol and racemic epi, and this is if someone's really interested into statistics, this is called a forest plot. And if you have lines that are going, this is a midline. So if your lines that are going across this, then they are not significant. That means your p-value is not less than 0.05, so they are not significant results. That means it did not make a difference. So bronchodilator versus placebo did not make a difference. That means they did not help. This one looks at nebulized hypertonic saline. A lot of centers, they actually have it in their protocol to use, hypertonic saline nebs. And what they found here is it was only more in the outpatient setting that it helped, not so much in the inpatient setting. And that's one of the reasons where in a setting, in a PICU or a floor setting, they may not work. But if this patient was seen at a PCP's office or in the ER, if they got hypertonic, that may prevent admission. That's what it says. Steroids across the board do not work in bronchiolitis. A lot of times, patients have already got a breathing treatment and steroids, before they come to us. But again, that's, a lot of adult providers who are seeing these patients. So, but again, if you're there to advocate for the kid, in our ER or somewhere, tell them this is bronchiolitis, steroids will not help. And a lot of times, I get this, albuterol helps. So sometimes kids need continuous albuterol for 4 to 6 hours, or maybe we should put them on steroids. But albuterol has a lot of other effects, and you're giving albuterol through a nebulizer, so it's going to have a lot of that saline, which is going to help with mucociliary clearance, and then they are not going to. So only because they responded to albuterol doesn't mean they need to be put on steroids, especially if they're less than 2 years. They do not have any atopy, they do not have eczema or anything. They do not have a family history of asthma. So you should be cautious about using steroids. And then this was again the only one that showed some significant was this study where they used Decadron and epinephrine racemic. So coming to other therapies. So one of the most important therapy, which has really revolutionized how we treat bronchiolitis, manage bronchiolitis, not treat, is the high flow nasal cannula. So this is heated and humidified. The usual dose is 1 to 2 ml per kilo. But sometimes when kids are really looking bad, you just start them on 8 or 10 liters or 15 liters, whatever they need. My cutoff usually for someone less than 2 years is usually up to 15 liters. If they're needing more than 15 liters, then they need probably positive airway pressure, so CPAP or BiPAP. I don't really use high flow more than 15 personally. So no one really knows what the mechanism of action is. And again, it's really interesting where, the entire world uses high flow, I guess. At least in North America, everywhere it's used. But really, there's no, really no one knows how it acts. A lot of studies will say it provides some PEEP. I'm not really sure if it gives any positive end expiratory pressure. What it does is it creates enough reservoir of air or oxygen at the back of your throat, and kids can get it from there, and then it just helps coordinate their worker breathing. We know it helps, but really no one exactly knows how it works. But yes, it's shown to reduce intubation rates, and this was the article that was published in Chest a couple years ago. So yes, we know it does work. Again, the CPAP is where when high flow doesn't work, and UK guidelines actually recommend using it for impending respiratory failure. I think it's a great bridge between intubation and high flow to use CPAP. So CPAP can be given through the mask, or you can do it through the RAM cannula. I've usually used RAM cannula less than 6 months age because they have smaller nares, so you can actually get some seal. If you're using it in a 2-year-old where bigger nares, it's just going to blow around it. You're not going to get that airway seal. I don't know what your experience has been, Todd.
Typically, that's about the same.
Yeah.
Any kids that we used to use is anything greater than we used a year, really, but it also depended on your size of your child. So, they may be a year old, but, they might be a micro preemie, and, you might be able to use a large bore gram on them. So it just depends. And then, you're basically, you might treat them initially with a RAM, but then if that doesn't work, just use a different type of interface, with a nasal mask or a full face mask, depending on the patient.
And again, when I say that albuterol racemic doesn't help, there might be that odd patient who you give some albuterol and that helps their vocal breathing. Sometimes if you think that if that's going to be the only thing that helps them, okay, we don't need to go to CPAP because you give them a racemic epinephrine neb and that helped. But again, every time we do an intervention, and you might have seen me asking, did that help? If you gave a fluid bolus, did that help the heart rate? Did that improve the perfusion? If you gave an albuterol neb, did that improve? What did it improve? Did it improve the heart? Did it improve the respirations? The respiratory rate? Did it improve the vocal breathing? So if you have an objective way to know what it did, that you can pass that on to your, that whoever is going to take care of that patient the next. Antibiotics don't work. The only thing that they're looking at is use of azithromycin. Azithromycin has an anti-inflammatory effect other than antibiotics, so they're looking at the use of azithromycin for anti-inflammatory effect in bronchiolitis. Especially RTs, you guys work with a lot of cystic fibrosis population. It has been, the every other day regime is like an anti-inflammatory regime they use it in CF patients. So they're exploring that option, but at this point there are no recommendations to routinely use them. And then hydration, so IV fluids, sometimes, and these are, the UK and Scottish guidelines recommend NG and OG fluids. And this is, I know a lot of our peds hospitalists will use a lot of NG, especially if you're not able to get an IV, then you can give them NG or OG fluids. Suctioning has been shown to help, so again, especially with kids who have secretions, sometimes they need every 2 hours nasopharyngeal suctioning to just get rid of all the mucus as much as you can. Chest PT, again, not routinely recommended unless you're intubated, and we'll come to that when we talk about ARDS, but a neuromuscular kid. So if you have someone with SMA who has an RSV bronchiolitis, I think it's going to help them so that you can clear out the secretions. Or if you have an MRCP patient who comes in with bronchiolitis, I think for those patients to augment their pulmonary toilet, chest PT would be helpful. But just a regular kid who can otherwise cough out their secretions, they really don't need a chest PT all the time. So prognosis, I think this is a lot of things, and this is more like from an outpatient, but a lot of times parents will ask us, okay, if my kid got RSV bronchiolitis, like what is the risk of them getting recurrent wheezing or asthma later on in life? And it's hard to say, and they looked at the study where they found that 17% of kids who had bronchiolitis before 3 developed asthma by age 10 compared to 11% in the controls. And the hazard ratio was 1.58. That means kids who developed bronchiolitis had 1.6 times higher odds of getting asthma than who did not. But again, the other argument to that was that kids with bronchiolitis probably had some altered immune response in airway function to begin with, so they were predisposed to asthma, because asthma we know is about airway function and your inflammatory response. So you don't really know if the asthma was because of bronchiolitis or because of something primary in their airway that predisposed them to, get sick. A lot of times we'll have identical twins, and one of them is at home, the other one gets intubated for RSV. So we really don't know, we know so much that which is the kid who's going to get sicker. So it's hard to say that. I think the take-home points, though it may sound cliche, the only two things that help in bronchiolitis is air and water. So, you need high flow, just respiratory support the lungs till the body recovers from the virus, and then hydration, either IV or enteral, is what's going to help them. Any questions? Okay, so we'll go to the ARDS. Okay. Can we take a 5-minute break really quick? Is that
Sure.
okay? Okay.
All those guesses, okay?